I'm John Strum, and this is Real Talk MS. It's June 3rd, and we have a lot to talk about. I spent last week in Phoenix, Arizona, attending the Consortium of Multiple Sclerosis Centers annual meeting, more often referred to as CMSC. While I was at CMSC, I had an opportunity to connect with old friends, meet new friends, and talk with some of the top MS experts in the world. One of the things I especially look forward to each year at CMSC is meeting up with Dr. Kathy Zackowski, the Associate Vice President of Research at the National MS Society, and getting her overview of the sessions and presentations at CMSC that caught her eye. In a moment, we'll hear my conversation with Dr. Kathy Zackowski. It's become an annual event that I look forward to each year at the Consortium of Multiple Sclerosis Centers annual meeting when Dr. Kathy Zackowski, the Associate Vice President of Research at the National MS Society, joins me to give us her perspective on some of the sessions at the conference that she found particularly interesting. Welcome back to the podcast, Kathy.
Thanks for having me. I'm glad to be here.
So, what caught your eye at this year's meeting?
Well, I've got a few things to share. So I thought I would start with the first meeting that I went to, which was on Tuesday before the CMSC meeting actually even started. And this is run by the Foundation of Consortium of MS Centers, and it's called the MS Mentorship Forum. And this is a room of about 100 clinicians who are in the final stages of training, so PhD and MD trained, and I was excited to be part of a panel of individuals invited to describe how and why we are so focused on MS in our work. And, you know, the panel included physicians and physicians from various academic centers, people in industry, and even the acting director of the CMSC herself, Kathy Costello, all sharing ideas on kind of lessons learned and tips for how to get started in the field. I really appreciate the approach that this forum has in terms of starting the Consortium of MS Centers, because this meeting is so focused on collaborative care, right? And I think the forum is trying to get that point across to these young clinical caregivers. And so the fact that it's so multidisciplinary, I think, is a really good way to teach them that this is the best way to care for people with MS.
I think a meeting like that, it would be so great if they could find a way to make it available, stream it, or put it online in video form for people who aren't at that stage yet, people who might be going through medical school thinking about where their specialization could be. It sounds like a great recruiting tool too.
Yeah, it's a good point. And or people that can't get here for the meeting, right, but still might benefit from it. Yeah, it's a good point. I'll bring it up to them. Good idea. The next thing I wanted to bring up was an early morning session on Wednesday. This is coordinated by the National MS Society, and this year it focused on wellness, both research associated with wellness and this new health coaching model that the society is doing. And I thought it was particularly exciting because wellness kind of took center stage. So we know that wellness is a high priority for people living with MS, right? Everyone, we want to know what you can do right now to feel your best. What are some lifestyle interventions that could alter the disease course or impact your symptoms? So we know that wellness is really broad and includes a lot of areas. And so it's not just, are you feeling well, but it's also your cognitive health, your diet, your spirituality, the relationships you have in your life, work and home life. So in response to this, the Society, about 10 years ago, created a wellness research working group. And this is made up of a variety of MS experts. I might have talked to you about this in the past, so people might be familiar. There is one particular facet of that working group called the Psychosocial Wellness Research Group. And this is made up of psychologists, physicians, occupational therapists, and physical therapists, and people who study behavioral interventions. And the objectives of this group are to generate and promote high-quality psychosocial wellness science, translate new evidence into practice, and to provide a network to collaborate and train junior faculty and students and trainees in wellness research. So what I learned, though, at this session was that there are three components of psychosocial wellness. It's emotional well-being, so kind of those positive feelings of happiness and satisfaction that you may have, but also it's psychological well-being. And this is a well-being that's associated with realizing your potential, living by your virtues and flourishing. And then a third one is social well-being. And that is social engagement and social embeddedness. So it's kind of a form of well-being that emphasizes meaning and purpose and self-realization. And so although we know what makes up psychosocial wellness, there's this huge lack of precision in our understanding of this in people with MS. And this is critical because we can't modify something that we don't understand. So the group started by talking with people with MS through a large focus group intervention. So focus groups that were made up of 10 people or so with MS, and they were asked specific questions, and those questions were kind of collated. From that information, they created a survey, and they gave this survey to 1,200 people with MS. And here's what they found. They found that psychosocial wellness is not very affected by factors such as sex, race, age, and even physical disability, which is a little surprising to me. But not surprisingly, psychosocial wellness is hard to sustain in the context of high emotional distress, financial stress, feelings of being discriminated against, high fatigue, and cognitive problems. And these findings highlight the need to study factors that are within a person, but also within their social environment. So we can try to modify maybe both of those facets to improve wellness for people with MS. A second piece of this session was on health coaching. And I wanted to share with the listeners what this is and why it might fill an important gap in improving a person's wellness. So coaching emphasizes this whole person perspective that recognizes multiple dimensions of a person's health. So a coach facilitates behavior change by empowering you to self-discover values and resources and strategies. And each person with MS, of course, is an expert in navigating their own life. So based upon, your own personal preferences and past experiences. So the coach provides the structure of the session and serves as a facilitative partner. And it's important to kind of keep in mind that the coach's primary role is not to be a content expert or educator. The coach helps the person uncover their vision and motivation and intention for making change. So the coach supports people in building a support system as well. So building the right relationships and tools and resources and environments that enable kind of ongoing success even after the coaching program would end. So this was a free program the society offered. They hired credentialed coaches who were hired and paired with people with MS. And the program required 6 months of weekly meetings. Results showed that the coaching was really effective at improving physical health and self-efficacy among participants. And in many people, the effects lasted up to a year after the coaching sessions. And at the end of the program, 83% of people agreed or strongly agreed with the statement that because of my participation in the coaching program, I feel more confident in addressing the challenges of MS. So I wanted people to know that this work is going on now, and the data is still being analyzed, so it's early days, but this is just the beginning of, I think, what is possible with this program, and it really might fill a gap of what's needed for people to improve their wellness without having to go to a licensed professional and going to people that are trained to do this. All right. Now, there's a couple of other highlights I wanted to share that are a little bit different. So I'll start with one. CHIMES, this is a phase 4 study that tested the clinical and radiological outcomes of Black, African American, and Hispanic Latino patients with relapsing MS. These are two historically underrepresented groups. They were on a medication called ocrelizumab, and this is an FDA-approved medication. So at this conference, they presented new data that revealed that treatment with ocrelizumab, and some people might know it as Ocrevus, that it has therapeutically beneficial effects on perceived symptoms, which are cognition and fatigue, specifically among Black and Hispanic Latino patients with relapsing MS. So I thought that was pretty exciting. Wanted to share that.
Well, I think it's great where you take a group that, as you pointed out, has been historically overlooked when it comes to clinical research and makes them the subject of clinical research. You can uncover, new insights that didn't exist before. As we know, there's been other literature to show that sometimes a medication is not as effective in those minority communities as it is among Caucasians. And so it's good to know that, hey, this is something where there's evidence that shows it's efficacious.
Yeah, and that it gets posted at a meeting like this where there are so many providers, so people are staying informed of kind of the latest research. Yeah, definitely. All right, so I'm going to take you a different direction again. So another session that I really appreciated was one that Dr. Anthony Feinstein led. So he's a professor of psychiatry at the University of Toronto. And he focused his presentation on depression in MS, such an important symptom. So we know depression is more common in MS than the general population. But one interesting point that he shared that really resonated with me is that medication and cognitive therapy in one study produced benefits for people with MS, and it wasn't clear if one was superior to the other. That's important, I think, because it opens the door for advocating to insurance funders and researchers the importance of behavioral interventions for depression that may be as effective as a medication. And the society's been thinking about this a lot too. This year we had a call for research applications that was focused on studies that could identify a self-management solution to support depression management for people living with MS. We know depression plays a significant role in people's lives as a consequence of the disease, and the society provides information and resources about depression that are freely available, and they have trained, MS navigators that are employed by the society and provide assistance and information. But a major limitation has been with these approaches, people are still needing to be encouraged or be shown how to utilize the resources on their own, and more specifically, how they could even self-tailor approaches to their needs over time. So it was really gratifying to hear Dr. Feinstein's information in light of this work that the society is also pushing forward. And the work, the society will be funding several of these studies, and the studies will all be 2 years in length, so we should have more resources soon.
That's great. I think the more that science can uncover non-pharmacologic interventions that people can take advantage of. So it doesn't necessarily mean, oh my goodness, I need to take another pill or injection or infusion. This is something that people can learn to really take advantage of without having to worry about side effects.
Yeah, exactly. And it's nice that there's, data that's coming forward so that people with MS can be more confident that these approaches are effective.
And in this particular case, the fact that so many people in the MS community at one time or another are going to deal with depression, it's an important unmet need that I'm glad to see is the subject of focus.
Yeah, and a lot of people came to his talk, so I think a lot of people see the benefit of this. All right, can I move on to another one that I don't want to use all my time up, but I have another study that I think is really unique and really focused on rehabilitation, so I wanted to be sure and share that. So Dr. Debbie Backus, she is a physical therapist, and she's also the Vice President of Research and Innovation at the Shepherd Center in Atlanta. She shared data from a study using a portable translingual neurostimulator. So this is a non-invasive device that you rest on your tongue. Yep, you heard me, your tongue. So there's a controller that you put around your neck, and then there's a mouthpiece that delivers mild stimulation to the surface of the tongue. So the goal with this is to promote neuroplasticity, and that is kind of changes to the neurons in the brain that control your movement. It wasn't entirely clear how that works, but that doesn't matter if it is effective. You can start with at least knowing its effectiveness. So this study did a combination of physical therapy and using this PONS device, this stimulator that you put on your tongue. And people in the study did this for 14 weeks. Now, it's fairly intensive in that it required about 2 hours of treatment, 6 days a week. And by treatment, I mean physical therapy and use of this PONS device. And some of the physical therapy is like breathing exercises. It's not all really, really active. But what they showed is that people were very adherent to the intervention, and they saw improvements in walking, which those improvements were sustained at 6 months. So this is something I think that, again, is perhaps in early days, although there might be a study near you that you could explore. The company that does this is called Helios. And I would just encourage you to keep your eye on it and be aware of any new data that comes out to, again, support the use of this.
Well, I know that when someone gets diagnosed with MS, one of their immediate concerns is, what is my future mobility going to look like? And my goodness, it's not often a study gets to report improvement in walking. So that's something everybody should keep their eye on.
Yeah, I agree. And it's another, this meeting is really great because you come across these little gems of innovative interventions, but you also get the really the large clinical trial data. And the other thing that's really wonderful about this meeting is just the networking and getting to talk with your colleagues in person.
Well, one of the little gems for me at this meeting is having you join me and give us these amazing overviews that just take someone who might be at home, takes them right into the meeting and gives them all the highlights. So, Kathy, thank you so much.
Thanks for having me. It was a pleasure.
One of the presentations at CMSC that I found to be particularly compelling was a panel presentation entitled, "If MS is One Disease, What Does That Mean for Our Clinical Conversations?" This panel of MS experts was moderated by Dr. Stephen Krieger, and I had a chance to catch up with Dr. Krieger to talk about this important topic and the thought-provoking panel presentation. In a moment, we'll hear my conversation with Dr. Stephen Krieger. Dr. Stephen Krieger is professor of neurology at the Icahn School of Medicine at Mount Sinai and a neurologist at the Corinne Goldsmith Dickinson Center for Multiple Sclerosis. And Dr. Krieger led what I consider to be the most interesting and most provocative panel presentation at this year's CMSC meeting. It was entitled, "If MS is One Disease, What Does That Mean for Clinical Conversations?" Now, if you're a regular listener, you might recall that over the past year, we've talked about whether the current MS subtypes, relapsing-remitting, secondary progressive, primary progressive, whether they're still relevant. Do they really do an adequate job of explaining or describing something specific about MS to patients and their doctors? So I thought this presentation was particularly well-timed. Welcome back to the podcast, Dr. Krieger.
John, thanks so much for having me. It's always a pleasure.
How often do you find that a patient's experience doesn't neatly fit into one of the current categories that are used to classify MS?
Well, as we've talked about before, I'm someone who feels that people in general are not categories, and that categories are a way of organizing things, but rarely do justice to an individual person's experience, especially with something as diverse and personal as multiple sclerosis. And, specifically, I've studied that even the way doctors write down what the diagnosis is in the chart can have a lot of uncertainty to it. And that between what we call relapsing-remitting and what we call secondary progressive is a period of transition and uncertainty that can go on for years in the neurologist's mind and is probably going on forever in the life of the person.
I sometimes wonder if any patient has ever actually been told, "I see you've just gotten secondary progressive MS." Typically, that's something that you only get to really diagnose in the rearview mirror.
I mean, you're absolutely right. It's diagnosed retrospectively because the way that category, that phenotype category was defined is a history of progression that has gone on for 6 months or more, and often much more. So one can never have a precise moment of transition from one category to another. And then I'd go one step further, maybe a little more provocatively, to say, if there's no moment that someone transitions from one category to another, are there really categories at all?
Well, we've already started answering my next question. In thinking about the presentation that you emceed with a phenomenal panel of experts, by the way, in addition to yourself, let's start with why is considering whether MS is one disease. Why is that important?
Well, one of the questions that kick-started the creation of this panel, and I'm really glad you found it provocative. I wanted it to be, because I think that, part of teaching is provoking people to think about things a little bit differently or asking hard questions. So the hard question that's kick-started the development of that symposium was one that one of my patients asked me. He's a 30-year-old man. I'd taken care of him for half a dozen years for MS. He's on a high efficacy therapy. He's had no relapses. He's had no lesions. He has no findings. He's a lawyer. He has 2 young kids. And at the end of a visit, of course, it's right at the end of the visit, you're hands on the doorknob, as the doctor might say. And he said, "My wife wanted me to ask you, is it inevitable that I will transition to secondary progressive MS?" And it's such a hard question to answer, and it's such a heavy question. Like, that's not a light question. And, of course, we're talking kind of philosophically about, are there really categories, right? But in the mind of someone who has a disease, a diagnosis, looks at information on the web, looks at the National MS Society information, there's these 3 types, and that's what they mean. Of course someone's going to want to know that. And the fact that I can't answer that question, or certainly the fact that it's an uncomfortable conversation, I think speaks to the fact that we need to start thinking outside of those boxes a little bit. And I'll tell you, we discussed it with the panel, and it was a great group of people. We had Dr. Carrie Hirsch from Cleveland Clinic in Las Vegas, Dr. Jiwon Oh from the Barlow MS Center in Toronto, Dr. Scott Newsom from Johns Hopkins, and Dr. Augusto Miravalle from Rush in Chicago. This is good that I just remembered all of that off the top of my head. But all of them had different takes on it and different takes on how to approach that question. But one theme that came up is to say to that person asking that, or to any one of your listeners wondering that kind of question, what are we really asking? And I think what was really being asked there was, am I going to develop significant life-changing disability? Is that going to happen? And, the short answer is we don't always know. We have factors. We have good prognostic factors. We have great medicines in many ways. We don't always know. And I think it's really important for neurologists and MS specialists to be able to admit our own uncertainty, even while we do all the things that we're doing to try to make the outcome as favorable as possible.
So, given that, if MS is viewed as one disease, how might that impact patient care?
Yeah, the idea is MS one disease, and I'll say there was not full consensus on this. I think at the end of the program here, we polled the audience, which was, about 100 people maybe, and 77% said, yes, MS is one disease. And the other 30 or so percent was less sure or wanted to stick with the categories.
Well, they were the ones who were on their phones during the presentation, I think.
Well, listen, you can't reach all the people all of the time, but you can reach some people. But, if MS is one disease, well, for people who've been told they have relapsing-remitting MS, no evidence of progression, it can be a little bit unsettling. What does that mean? I no longer have relapsing-remitting MS. And, it's because it's been a comforting category. But we know that there's evidence of progression that can be subtle and can be biological that we can't always pick up. For people with secondary progressive MS, being told, well, now that's not a category anymore, that's not a thing, there's only one MS. Well, maybe there's a little bit of optimism baked into that, because I think the category SPMS has always been very foreboding. It presupposes that things are only going to get worse, and we know that that doesn't always happen. So I want it to be more honest. I don't want it to make people uncomfortable to say, what do I have now? I think it gives us an opportunity to say, let's not think in these boxes. Let's pay more attention to you and not categorize and not say you have relapsing-remitting MS, therefore nothing's wrong. Things might be wrong, and we need to pay attention to that. And not to say to someone with secondary progressive MS, well, you're destined to get worse, because they might not be. And there's a lot of more empowering things people can do to stay stable and stay well and keep their brain healthy. And I think we need to be open to that.
Well, I can see where, when we're thinking about how it might impact the clinical conversation, I can see where, it's going to end those conversations that leave the patient really confused, because they'll hear, you know what, there's nothing new on your MRI scan, therefore your MS is stable. And they know since the last time they saw their treating physician, they're not doing as well. Something's a little bit worse than it's been before. So they walk out of that office thinking, I didn't get my concerns really ever addressed in the conversation. And the expert who is in charge of my treatment plan just told me I'm stable, but I don't feel so as stable as I did before. Maybe he or she doesn't really understand either.
I think those are real conversations. Your podcast is Real Talk MS, and that's the real thing. That's the real conversation that happens. And I'll be honest, I struggle with it as someone who takes care of people. Sometimes I really can't find any evidence that anything is worse. And in some ways that's good news, but it doesn't always do justice to what the person is feeling. And then I think the mandate needs to be to listen more carefully and to look harder and to take it seriously. You and I talked a year ago about looking below the surface, and that the EDSS, our disability scale that all the clinical trials use, is imperfect, that the idea of somebody having an EDSS of 0 being perfectly normal is not true. It just means we hadn't looked carefully enough. And I think this conversation is in many ways an extension of that. It's saying the mandate for us as physicians, clinicians, people who treat patients with MS, is to center around the patient's story and their experience, and not the labels that we have put on it for a long time.
I could not agree with that more than I do. I think you already know. And it occurs to me that the difference here, well, several, but one of the big differences is that clinical conversation really becomes an evolving, ongoing dialogue that occurs and gets updated, as opposed to kind of a set of, we check the box, as you pointed out, there's no signs of progression, and therefore you're not progressing, and someone walks away very confused. I think instead this becomes a real conversation, and what it sounds like is it opens a door to more personalized care, where that patient who's in front of you, their issues are the ones that are going to be addressed.
Oh, as you said it exactly right. It's personalized care. Categories are not people. And so getting away from categories and thinking about people and their individual experience with a disease, I think, is necessary to personalize the care. It came up in the symposium that we led. Dr. Newsom talked about how we can assess patients in a more personalized and detailed way with wearable technologies, other ways of monitoring folks, to get outside of just the quick exam in the office. You look fine. That's not good enough. So he looked at that. Dr. Jiwon Oh talked about several things, but MRI in particular, that just because the MRI scan is stable, well, the MRIs that we have are not perfect. New technologies and new sequences on the MRI scan are going to show us things on the MRI that we didn't see before. So it allows us to look in more detail there. And perhaps the most kind of personalized aspect of it came from Dr. Hirsch and Dr. Miravale, who talked about how can we harness well-being and tools and techniques and strategies to foster brain health and body health and mental health. All of those are personalized, because there's obviously no one-size-fits-all way of making everyone's brain as healthy as it can be.
Well, as I said a couple of minutes ago, I found this presentation to be the most compelling of them all. Having said that, switching gears for a minute, when you look at the MS research landscape, what excites you?
Oh, that's a tough question. Yesterday at CMSC, I was one of the presenters in the sort of clinical trials science update. And it was a whole series of presentations. And what I thought was really remarkable, mine was the last one of the day. I talked about the phase 2 trial data for a medicine called frexalimab, which Sanofi is developing. And it has done very well in the 2 years after its phase 2 trial and is now in phase 3 trials. And it has a totally novel way of working, which I won't get into here, but it has just a mechanism that has never been used in MS before. Before my talk, there was a talk on fenebrutinib, which is a medicine that Genentech is developing. They also supported the symposium that we were talking about. Fenebrutinib is a BTK inhibitor that's being looked at in progressive and relapsing MS, and this was 2-year extension data from their phase 2, and that was successful. There was a talk on a CAR T therapy by Dr. Claire Riley from Columbia University in New York. She talked about preliminary data on how this entirely novel cell-based mechanism could take out B cells in a way we've never done before. So right there in this one session were 3 or 4 entirely new mechanisms that we don't have available to us in practice right now that are all on the cusp. And as we talk about personalizing treatment, it'd be nice to have medicines that work in a whole new set of ways to treat people in a whole new set of capacities.
Well, I want to thank you for all the ways you treat people today who are living with MS, all the ways you pioneer future treatments as well. Thanks so much for talking with me. It is always my honor and pleasure.
Listen, it's my honor and pleasure too. And as the field keeps moving, I hope we can keep doing this again.
Count on it. That's going to wrap up this episode of Real Talk MS from the Consortium of Multiple Sclerosis Centers 2025 annual meeting. Real Talk MS is powered by the National MS Society, and you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/405. You'll find that link in today's show notes, so you can easily copy and paste it right into an email or a text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes, and it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.